specialist advisors and bank inspectors, and we deal with all matters relating to these roles. So we've got three main functions. We do the onboarding, the engagement and scheduling of flexible workers. And our specialised sub-teams offer a personalised service to all casual workers and secondees. We appropriately support the directorates within the management of the highly valued workforce within CQC. So, as I said, we cover onboarding, engagement and scheduling. We've currently got 2,339 SPAs and 176 bank inspectors. We're a relatively small team for managing that number of people, and we're based in the Newcastle office. As you'll be aware, there's two types of terms of engagement for specialist advisors. We've got casual workers agreement, which the majority of SPAs are on, and we also offer an inward secondment agreement, and this is where you'd be released by your substantive employer to complete CQC work. Again, with you being existing SPAs, we would imagine that you'd have those terms in place and that you'd be on the correct terms. But if you do have any queries around your terms of engagement, then please don't hesitate to contact a member of the team. So moving swiftly on, one of the systems that we use quite a lot in our work is the Signum system. And we use this mainly around the scheduling of SPAs, but we also use the information that SPAs have on their profiles on Signum to ascertain their suitability and also to follow up if there's any areas that haven't been completed as part of their profile. So when you first onboarded as a specialist advisor, or for those of you who've been around a few more years than that, and were around when Signum was rolled out, there's an expectation on you to add to Signum your conflicts of interest. So this will stop you from being allocated to any inspections where you might have a conflict of interest. We would also ask you to update your bio or pen profile on that on your Signum portal. This is where you can give us some more information about your current or your recent experience, and we can use that so that we can share it with inspection teams to make sure they're getting the people with the right skills. You can also indicate your availability or your non-availability on Signum, and you also use Signum to accept or reject invitations to inspections. So there's a little checklist here on the slides of what you would need to do when you get your Signum login, or just to make sure that you maintain your record. So on the About Me page is where you'll find the bio. Mentioned there conflicts of interest, availability or unavailability. There's also some documentation on the SpA portal. So this will be the Signum guidance, and there's other various documents on there that you might find useful. And again, as I mentioned before, accepting or rejecting inspection invitations. So obviously, to get to inspections, you're going to need to arrange travel. So we do prefer SPAs to use public transport where possible. So rail travel tends to be the most popular form of travel for SPAs. And you obviously need to know about payments. So with regard to travel, all rail travel and accommodation that you need for your inspection should be organised through either the inspection planning coordinator or this travel web form on the web page. This is so that we can make sure that all of the travel and accommodation is within budget. We also get a government rate reduction for all rail travel and accommodation. So although you may think that there's a cheaper deal with Railcard, it may be that actually we can get that at a cheaper price through that. It's worth mentioning to you that accommodation and rail travel must be booked through CQC because it's not claimable under the SpA expenses policy. So therefore, if you paid upfront for a hotel, it may be that you wouldn't be reimbursed for that amount unless it was in extreme circumstances. There is a copy of the policy on the web page, so it's worth having a look at that to ensure that you know what can be claimed for. It's just worth mentioning around ID badges. We do receive quite a lot of queries around ID badges. SPAs aren't provided with CQC ID badges. I think one of the main reasons for this is around the volumes and about managing those cards. Therefore, you're expected to carry some form of personal identification, and you'll be provided with a warrant letter when you arrive at the inspection.
Can I just make a comment there, Sue?
Of course,
Can I just make a comment there?
Yes,
I think it would be helpful for inspectors who we're supporting to at least have a badge which identifies who you are. Because to be honest, to be walking around having to flash your driving license, hair staff, it's just not very suitable at all.
Yeah.
And if you're part of a team that is in an establishment or somewhere, you need to be clearly identifiable as to who you are, even if you have to hand the badge back in afterwards.
Yeah.
Because I've been doing this for 4 years now, and I've kept giving this feedback, and yet nothing seems to change, actually.
Yeah.
And I can understand there's logistic issues about issuing warrant cards or whatever, but, there must be a simpler system to support SPAs.
No, and I have made a note. Sorry, what was your name?
It's Ian Conyers.
Oh, hi, Ian. So
Hi.
it is. I've just made a note of that, Ian, because it is something that does keep coming up, and it's recently been raised to me by the Primary Medical Services Directorate as well. So it is something that I am going to keep raising, and see if we can reach some sort of solution with that. I know that some inspectors and some inspection planners in hospital inspections do take, kind of just a blank CQC badge on a lanyard.
Something like that.
Yeah, and I think it is something that we need to keep looking at and keep going back to make sure that it's just difficult. Like you say, if it's your driver's license, I know that a lot of SPAs have NHS ID, so like for your own hospital or your own employer, but again, it's not marked with CQC, so it is an ongoing conversation, and we need to sort of look at what's a practical solution for it.
Yes. Okay,
But
thanks.
Thank you for that. That's really helpful of you. Okay, so quite aptly, we'll move on to feedback. And this is again, it's around making sure that everybody's involved in the inspection process. So we appreciate that different inspections are very different to one another. And what we try to encourage is that we receive feedback on that. So whether this be feedback from the lead inspector on how the SPA's done on the inspection, what their involvement's been, but also from SPAs as to if there's anything that they felt could have gone better on the inspection or anything that was done really well. It's all about reflection and trying to improve our practices. So it's really helpful if we can have that feedback. Where the lead inspector for the inspection submits feedback on SPAs, that is monitored by the Flexible Workforce Office. It's then shared with individual SPAs. If there's any concerns that are raised within that, then we pick that up individually with the SPAs and either an inspection manager or a national professional advisor, and just to ensure that the SPA's aware of that feedback, if there's any learning to take forward from it. And quite often we do find that we deal with quite a number of feedback cases. I think we've got about 30 open at the minute. we tend to find that SpAs are quite open to receiving that feedback and also provide feedback back to the directorate as to how we can improve our processes. It's also quite handy, I think, for revalidation, the inspection feedback that SpAs receive. So it's worth encouraging inspectors to submit feedback or to provide you with feedback off the back of your inspections you attend with them.
Can I just, make another comment now, Sue? I've never had any feedback in all my time working for the CQC. I've never had an annual appraisal or something which have indicated any sort of revalidation other than.
No, I mean, for your professional registration, the revalidation is.
Right. Okay.
Yeah, we don't do regular appraisals because you're flexible workers. We don't do appraisals, but what we do is have the feedback process there. We don't.
It's Pauline Hopkins here. I just want to add that I've not received any feedback from the inspections that I've done either, and I'm assuming that's a good thing because there's not been no concern. But actually, it would be really, really helpful to have, we're asked quite, often on surveys and individually at the inspections about how we think it's wet, how I think it's gone. But I just feel we don't get an understanding of whether they felt we've contributed well or sufficiently enough or whether actually they've really appreciated it and we've done a good job. But it would be quite helpful to have some of that and I understand there's an awful lot of paperwork to get through and it is quite challenging to maybe undertake some of that, but I think it would be helpful.
Yeah,
I would second that, particularly around the reports we write. So we don't get feedback on those either necessarily.
Okay.
Can I just, sorry to interrupt, Sue, can you just clarify, specialist advisors don't write reports? Do you mean the notes that you provide, the evidence?
Yeah, so the feedback that we give, the written feedback, it would be useful to know, is that in enough depth? Did they want something different? It's not always easy to gauge, as we say, because we don't get the feedback, exactly if we've met the requirements that they wanted that day.
Okay, we will share that with the inspectors. Thank you for that feedback.
Yeah,
that's really helpful.
I think, like you said, I can't remember who it was who said they hadn't received feedback, but we're guessing that was a good thing. Pauline.
All right, it's okay.
So yeah, I think if you haven't had any concerns raised, then I would take that as a positive. However, I do take on board exactly what you're saying, that it is really helpful to have some feedback there, to know what you're doing well and if there's anything you could improve on. And I think it's really important that we do try and share feedback with SpAs. I can assure you that if any has been received by us, it will be shared with you. But we're just not able, sort of volume-wise, to go out for feedback on every inspection. There is a functionality within Signum that's kind of a reminder for inspectors to submit feedback, but I think, like Helen said, we can share that with inspectors and try and encourage them to share feedback with SpAs more often.
I think, to be honest with you, over my time, and I've been since it was set up, so quite a few years. I think I feel as if I've received some feedback just through normal dialogue. Just like, yeah, that went well, and thanks for that, and that was enough for me.
Yeah.
I think if it was a particular issue, then I would expect it to be sort of taken up formally, but just through sort of general discussions before, during, and after the inspection I've always found that pretty helpful.
Yeah, that's good.
Can I just make a comment? Sorry, I know we're talking about feedback, but this query is that I've been with CQC from over 3.5 years, So initially I used to get a lot of invites and then I used to accept it. But I don't know what has happened in the last year and a half. I will get the initial invites and I believe that I'm doing the immediate reply as well, that I'm available.
Yeah.
But the email response which I'm getting back is, either the inspection is being cancelled or there is someone else who have been taken over. So I'm not sure, is it because of the postcode where I'm living? I'm live down south, but I'm not, in the last year and a half, I have not done any inspections.
Okay. And what was your name, sorry?
Jeevan Sharma. And I'm exactly the same, actually. It's been a long time since I've done one too.
Can I?
Yes, I'm in a similar position actually as well. I have done one or two in the last year, but then again, I've met with other SpAs who've told me they're incredibly busy, and it's sometimes very difficult to gauge what's happening.
Yeah.
So
I
can just give you an update on that. Sorry.
Thanks, Helen. No, that's fine. That's absolutely
fine. It's Helen Vine. So obviously, from an operational perspective, you will understand, most of you, that our inspection activity is risk-driven. And if you look at the ratings for the majority of community health services, they're either good or outstanding. So per se, it is that activity will be lower in this particular sector. Because the inspection frequency ratings mean that we don't go back to services as often. So there's lower activity, and where there is activity, it may be focused around the smaller or independent providers where we need fewer specialist advisors. So generally, the rate of inspection activity and the requests going out is diminished for this particular sector, but that doesn't mean to say that situation can't change, because obviously it is risk-based. So I hope that explains it. So other SPAs may be busy because they may also, a lot of you are registered for more than one core service or one specialism, so it may be that they're busy in another sector rather than in community health.
Thank you, that's helpful to know. Or reassuring.
Yes.
Yes, it's not that we don't want you, we definitely do. We've done campaigns, so we definitely need people. It's just that the levels of activity might fluctuate.
Okay, thanks.
Yeah, that's helpful. Thank you.
Okay, so just moving on to, so this is kind of just a summary around flexible workforce office. So what we try to do from an engagement perspective with SPAs is we'll have ongoing contact and support and notify you of any changes that are relevant. We send out a SpA quarterly bulletin, which hopefully you'll all have seen at some point. I think the last one went out in November, so we're due another one to go out this month. We'll also contact you to invite you to inspection, so that might be via telephone, signal or email. We'll also may request information from you periodically. I think all of you on the call will have completed the annual declaration last year, which was part of our review piece. And it was a huge piece of work across the full SpA pool. So, thank you very much for engaging with that. It really helped us. And we also provide support needed. So if you've got any queries regarding HR matters, payroll, inspection opportunities, that kind of thing, you can contact us. And we also update you on any changes to circumstances. So anything where we've got system change, anything that kind of affects you directly. And then the final slide from me is just around the support and how to contact us. So there's some links on there for any recruitment queries, engagement queries. So that's anything HR related, scheduling queries, and then feedback. So if you've got any feedback on inspections, we've got a mailbox there. So does anybody have any questions around flexible workforce office?
No, that was really good. That was really informative. Thank you.
Okay.
Thank you.
Thank you very much.
That was very helpful. Thank you.
Oh, thank you so much. Okay, so if we move straight over to Helen to speak about policy.
So I'm
Thanks,
Helen
Helen.
Hayton, and I'm a policy manager in the primary care and community health services team. Sorry, I've got a slight cold, so excuse me. I lead on the community health side and also hospices. And I did notice earlier that I've got one slide where I've left the word hospice in, because I've used these slides before for a similar presentation for hospices. So I've asked Sue if we can send out some revised slides afterwards. The role of policy is really about being kind of forward looking and thinking about how services and the sector is changing, understanding the sector and engaging externally, and also development of methodology. The slides I've got here give a bit of an overview of sort of where we are with CQC, what our aims are, a little bit about our strategy that we're actually coming towards the end of, and a sort of overview of the end-to-end process. So I'm going to go straight on to the first part of that, which is an overview of CQC. If you've got the slides in front of you, that's slide 15. So I think I'm hopeful that a lot of these slides will be quite familiar to you in terms of content if you've been working with us for a while. We'll have time for questions at the end, but please do stop me as we go through if there's things that you want to ask. The main role of CQC is to make sure health and social care services provide people with safe, effective, compassionate, high quality care, and we also encourage care services to improve. And there's a number of things we do to try and meet that purpose, and I'm going to go into those in a bit more on the next slide. But basically it's about registering providers, monitoring and inspecting them, using legal powers, using our independent voice to say things externally about the state of care, and encouraging improvement. And very much at the heart of what we do is the people who use services, and that people have a right to expect safe, good care from the health and social care services. So the next slide shows our model of regulation, and that there are 4 parts to it. And the parts that you're generally involved in is the purple parts, in monitor, inspect and rate. But I think it's useful to understand how that fits into the wider model. So the first part is about the register, and that's our sort of our gatekeeping part really. So where we register providers who apply to deliver health and social care services. I'm sure you know a bit about the regulated activities, and I don't want to go into detail of it. But basically we have a document called the Scope of registration, and that sets out what activities people provide or providers deliver that have to be registered with us. And it's that brings providers into regulation. And that means that we go on to the next part, which is monitor, inspect and rate. So we actually do a lot of monitoring behind the scenes that's not part of the inspection. And I will come on to that a bit more later. The inspection is actually quite a small part of what we do, but it's a really important part. And that's where we go out and see services and where you can get involved. Obviously, sometimes that leads to enforcement, and again, that's another important element of what we do, because we do have legal powers and can prosecute providers. And then finally, a bit that gets forgotten a lot, I think, is our independent voice. So obviously, publishing reports about inspections is independent voice, but we can also say other things about what we find. So we have an annual state of health and social care report that we publish. And we've also done a number of thematic reports. I think on community healthcare, it's fair to say that there hasn't been that much specific that we've published. Community health was quite a big element of the local system reviews. And I don't know if you've seen the reports from those, but they're quite interesting. But going forward, at the moment, our independent voice panel is considering topics for this year, and there is a community health topic on there that's quite likely to go ahead. And we also have a series of reports that look at improvement of providers. So providers that were rated perhaps inadequate or requires improvement and have improved 1 or 2 ratings above that. And they've been published by sector. And again, this year there will be one about community health. Okay, so the structure of how we look at services is all around the 5 key questions which we introduced back in 2014. Again, I'm hoping these are all really familiar, but I will go through them quickly. So safe, and by safe we mean are people protected from abuse and avoidable harm? Are services effective? So do people's care, treatment and support achieve good outcomes, promote a good quality of life, and are they evidence-based? I think this one is one that in the past we've sometimes struggled a bit with community health, just because it can be quite hard to evidence that somehow, to show how services are being effective. But I think we've enhanced the frameworks, and I know I've certainly had less feedback about that that key question being as difficult as it has been in the past. But I suspect that that's one where SpAs would be quite helpful to teams. Are services caring? So do they involve and treat people with compassion, kindness, dignity and respect? Are they responsive? Do they meet people's needs? And are they well led? And I think the well-led one is really important, because I think actually that underlies a lot of what else is going on in a provider. So whether the leadership, the management, the governance of the organisation is assuring delivery of high quality care. I'm just going to pause for a second and say, does anyone have any questions at that point?
No.
I feel like I'm rushing through this, but I will just keep going. So the next couple of slides are about the strategy, which is 2016 to 2021. So we're coming to the end of that period, and we're already developing the strategy looking forward beyond that. But I left these slides in because actually I think that the context of the strategy that we're coming towards the end of, shaping the future, is actually still relevant. So that strategy was developed thinking about the fact that the environment is changing. So the use and delivery of regulated services is changing, and that CQC must deliver its purpose with fewer resources. And I think those two things still stand as background when we're thinking about going forward. In response to that, CQC set out that they needed to adapt and improve to become more efficient and effective, and to stay relevant and sustainable. And Helen Vine mentioned earlier about core service inspections and how we're not doing comprehensive inspections where we look at everything. And that's something that's come out of the strategy about being efficient and effective, and being more risk-based. So the ambition of that strategy was to deliver a more targeted, responsive and collaborative approach to regulation, so that more people get high quality care. And there were 4 priorities underneath that. So they were about encouraging improvement, innovation, sustainability, delivering intelligence-driven approach to regulation, which we'll come on to in the intelligence slide, promoting a single shared view of quality and improving our efficiency and effectiveness. And I think we have made progress against those 4, but there's definitely still more to do, and that's something that we're thinking about now going forward beyond next year. It's a quick overview of sort of the strategy for CQC. Going into more detail, the next few slides go through our end-to-end process. So the first part of that is monitoring and pre-inspection. And as part of delivering a risk-based approach, I think this element of what we do has become more and more important to us. So we've worked quite a lot to strengthen the relationship management that our inspection teams have with providers on an ongoing basis. So providers have a relationship owner who contacts them throughout the year and who we'll meet with them and try to understand what might be changing in that provider, and any risks that might be developing or any concerns. And I think that's really important because it allows us to understand things in advance of inspection, to understand what the service is delivering and identify risks to focus our inspection. As part of that, we also work with national partners and with local and regional partners to understand what might be happening within an area and how that might relate to specific providers. And then we have the provider information request, which goes out for NHS trusts on I think it's a roughly annual schedule in advance of the inspection process, and the same for independent providers in advance of the inspection process. And I know, again, that's covered in a lot more detail later on, but that is also about us capturing information to understand the service and identify risks. So by the time we get to the on-site inspection, we should know quite a lot about what the provider is delivering and where we think the concerns are. There are different types of inspection. Partly these relate to the types of provider. So I think community healthcare can be delivered by NHS trusts, it can be delivered by a standalone NHS trust that's just doing community health, or a combined trust that's doing a combination of mental health and acute as well. And also we know that these services are changing, and increasingly we have services that are delivering elements of primary care and social care as well. We also have a number of independent healthcare providers. Some of these are delivering quite small services. Others are actually delivering a service that much more resembles what we see in the NHS. And for those providers, where they're large IH providers delivering a range of core services to a geographically contained population, we actually put them through the NHS process, so through the NHS methodology, because it just seems to make more sense. Effectively, they are providing the services like an NHS trust. It's just that they've taken a different form. Sometimes they're CICs, but not always. There's a bullet point on here about the inspection team, which will vary depending on the type of service and the type of inspection, but will include or may include inspection managers, inspectors, yourselves, experts by experience. In some complex providers, you might find that there are inspectors from other directorates as well. So there might be inspectors from the PMS directorate, for example, or SpAs from other directorates. So the next few slides, and this one doesn't have a number on, so I can't tell you where I'm up to, but it's on-site inspection. Go into this in a little bit more detail.
Slide 22, Helen.
Oh, thanks, Helen. So on the NHS side, our model now is a core service with well-led inspection is what we usually do. So it's approximately annually. It's provider and service level. So we'll ask all 5 of the key questions in at least one core service, followed by an inspection of how well led the provider is. The well-led inspection is announced following the regulatory planning meeting, and the core services, which are also agreed at that meeting, are usually either unannounced or short notice and take place in advance of the well-led inspection. For community healthcare, often we find it's useful to give short notice because the services are often geographically dispersed. It can be very difficult to plan unless you're able to give some notice and understand where services will be delivered on particular days. But you know, unannounced, I think we aim for unannounced and do short notice where we need to. The inspection frequency of the core services relates to their rating. So for an inadequate rating, we would expect to go back within 1 year. Requires improvement 2 years, good 3.5, and outstanding 5. And then on the independent health side, which is the next slide, So for independent health, we'll usually do a comprehensive inspection. When we say comprehensive, what we mean is we're looking at all the services and all the 5 key questions in a location. Often for independent health services, they're only delivering one of the core services anyway. These inspections are unannounced or short notice again, within 3 months of the deadline for the provider to submit the provider information request. So it's unannounced, but there's a little bit of warning actually, because if you get the PIR, within 3 months there will be an inspection. The inspection frequencies are the same as those for the NHS core services. So the core services themselves. We divide our core services, or the services that community health delivers, into 2 categories. So one is core services and the other is additional services. Core services are the services that we would expect a standard NHS trust delivering community health to be providing. And obviously this is some time since these were developed and things have evolved since this time. We also have additional services, and those are ones where we will only look at them if we think they're a significant element of what the provider's doing, or if we've identified risks and concerns for those services. I think my view is that for community health services, some of the ones that we have as additional services, actually they're often a significant part of what that provider does, and they'll be something that we will always look at. And once we have inspected the additional service, they would follow the same inspection frequency unless they stopped meeting the criteria to be an additional service. So usually if we've looked at community dentistry or sexual health, urgent care previously, unless something's changed in terms of what they're delivering, we're likely to go back and look at them again at some point. I don't know if you want me to go through the core services. I expect you have some understanding of what kind of things fit under them, but just briefly, particularly on the core services. So community health services for adults covers all the health services that are provided for adults, the community health services. A big part of that is community nursing, but it also covers condition-specific services. So there might be community diabetes service, for example, a number of other things that can sit under there, including various rehabilitation services, community-based ones, therapy services. If you look at the framework, which there should be a link to, but I think it needs updating in the slides, you'll see a lot more detail about what's covered. Community inpatient services is probably quite self-explanatory. They tend to be things like step up, step down wards, rehabilitation wards, those types of things come under there. Children, young people and families, a big part of that is health visiting and school nursing, but there are also a lot of other community services that are provided. So for example, specialist community services for children with long-term conditions would come under there. And then we've got community end-of-life care, which I think is probably quite self-explanatory. Hospices have a separate core service framework. So if you did come across a community health service that was delivering a hospice, it would be looked at separately, and we have separate SpAs that cover hospices. So the core service frameworks guide the inspection team in their inspection. They're structured around the 5 key questions, and each key question is underlined by key lines of inquiry, or CLOEs. And the CLOE itself has a number of things sitting under it. So there's generic prompts that apply to all healthcare services. And then we have links to professional standards and relevant guidance. And then we have some sector-specific prompts that have been developed to encourage the inspection team to ask questions that are relevant to that specific service. After the inspection, there's a process of QA, quality assurance, and also it doesn't sound a process of factual accuracy checking, so where the provider is given the opportunity to check the factual accuracy of the report. and then that all leads into publication. And ratings being awarded. The ratings are awarded at different levels related to the inspection, so we sort of covered this, but the NHS trusts are given a provider level rating and then core service level ratings, and then independent providers will have a location level rating, and obviously you can have enforcement action as well. And then the last slide just gives you a little bit of understanding about the ratings characteristics. So it's not that inspection teams pluck them out of the air. We actually have a document that sets out what we're looking for different ratings. And this is just an example of one about can people access care and treatment in a timely way. And that's pretty much all I was going to say about the process and about the sort of background to what we do. I will get the link updated to where the frameworks are on the internet in case you want to look at them. Do people have questions?
Can I ask if there's any consideration being given to any change in the role of specialist advisors, particularly given what, if I've understood it, a slight change in strategy towards supporting providers in between inspections. And I just wondered if the role of SpAs is just going to continue as it is at the moment, or if there will be any change in the future.
So when you say supporting providers in between inspections, I'm not sure we'd see it in quite that way, although I think part of it is around support. I think it's more about ensuring that we have ongoing engagement to understand where they are rather than actively supporting.
Well, I suppose I was thinking more in terms of when he's trying to develop models of good practice and particularly develop out, that are increasing the number of outstanding ratings, which one of the dilemmas I've often found as a SpA is this issue about giving advice on inspections, which different inspectors I've been with have taken very different views on at times. And there is, to me, I guess, an issue about specialist advisors being able to use their specialist knowledge at times more effectively beyond just the inspection.
I think that's an interesting point about how specialist advisors are used beyond the inspection. I don't think we haven't considered it as part of the relationship management side of things, and we don't have any active plans for changing the way the role is used. I can take that away and have a think about it.
Helen, it's Helen Vine. Sorry to cut across.
No, it's useful.
I think that was Ian, was it, with that comment?
It was, yes.
Yeah. So obviously from a strategy and policy perspective, that sits with Helen, and you're asking about the future. But what I can say is that there have been examples in the recent past where we have contacted specialist advisors for a discrete piece of work that is not inspection related. So it might be analysing some evidence that's been provided to us around a serious incident, for instance, in the sector, and where we don't have the specialist knowledge in-house, we've come out to specialist advisors for a time-limited piece of work to give us support. We have done that in relation to training as well. So sometimes we've contacted specialist advisors and asked them to support us with some specific training activity. And most recently, in fact, in the last week, we have contacted a specialist advisor to support us with the police have asked us around an inquest to ask for a specialist to support. So there are occasions where we do request specific input from specialist advisors that isn't inspection related, but they are ad hoc at the moment, and it isn't a strategic approach. If that helps.
Okay.
I would definitely agree with that.
Hi, this is Jeevan. Can I just make one more comment? It's regarding the PIR information. So, I may be wrong if things have changed in last year or year and so. is I currently am working myself as the CQC registered manager for an independent enablement agency. And when I was filling the PIR information, realized that there are a lot of questions which probably might be helpful if it is shared when shared with SpA. If they are going out and they have that information in hand, that might be most useful.
I mean, Helen, I don't know if you can say anything on that. I don't think there's a policy that says that we can't share that information with a SpA if we think it would be useful.
No, and I will cover it in my section, but basically it's up to the inspector who's leading the inspection to share what information they feel is relevant. So I would expect them to share that information, but they might not share it in the format that comes in the PIR, because it's quite, well, it's lots of spreadsheets with tabs and different things. It's a bit difficult to navigate. So they may well put it in their plan and summarise that evidence, but I would expect it to be there if it's appropriate to the bit that you're going to be looking at.
Okay. Thank you.
Do we have any other questions on the line?
So, Helen, thank you for that. We do actually have one of our analyst intelligence colleagues with us who, and a big thank you to Dean Johnson for stepping in at the very last minute to cover some colleague absence. So he really is winging it. So please be kind to him with your questions. Thanks, Dean. Over to you.
Yes, thanks. Okay. Hi everyone, I'm Dean Johnson, I'm analyst team leader in intelligence, and I deal with acute and community side of the inspection schedule, and I'm just going to go through the intelligence to monitor and inspect bit of the call with you. So the intelligence approach to monitor and inspect, I think the guys have talked about the RPIR going out. So this is sent directly from one of our teams, and then trusts have to supply the information, and they're given a set period of time to submit that information. All trusts get the same amount of time to submit that information. If they need extensions, then that's granted on an exception basis, but everyone technically does have to fill it in the same time frame.
Dean, is that the same for independent health as well?
I think it is the same for independent health as well. I'm not sure if it's the same time period, but it's definitely the same, that they would only get a set amount of time to actually fill that in. Once that information has come back from the RPIR, there's a team of analysts that do a lot of validation on the actual data that comes back to make sure that it is fit for our purpose and that we can get some usable intelligence from that. The next phase that we'll move to in the inspection cycle is what's called a regulatory planning meeting, or an RPM, where the decisions are made on what core services we are going to inspect. So intelligence colleagues work with the operations colleagues, the inspectors and the IMs to come up with recommendations based on intelligence on what we think the riskiest issues are in the trust. This is only for community services, it's not for independent health. And I think that's the big difference in the inspection cycle, is there's no RPM for independent health inspections. Once the decision's been made on what core services to inspect, we then move on to the inspection stage of the cycle. What the inspection stage means for colleagues in intelligence is we start to then put data in the evidence appendices, which show data and trends, and the inspectors and inspection managers use these to identify key areas for yourselves to follow up on inspection. And then the next stage is the reporting stage, where yourselves and inspectors would go out on inspection, but then actually write the report based on everything that you've found whilst on site. In intelligence, we won't really get involved that much at that stage. We will only get involved if you've found something on site which contradicts the data that we've provided prior to the inspection. So, if we've stated a certain figure and you go on site and the trust is saying, no, that's not that figure, it's this, then we can get involved to find out the meaning behind that. So the next slides just go into a little bit more depth about the provider information request. It's sent to the trust 9 weeks prior to the RPM and contains questions around trust-wide information, some detail about the core services. The trust has 3 weeks to complete it, and we take around about 1 week to validate all the information, and then a further 3 weeks to analyse it prior to the RPM date. Certain elements of the data in the RPI are we ask the trust to self-rate themselves, which is a good source of information to actually see how the trust actually think they're actually doing. And it really is always good to have a look at that to say, do a trust think they're outstanding? And then, we turn up on site and we really see that they're not outstanding. Then, we can have them conversations about, do they actually know where the risks are in their services? We get a whole host of what we call intelligence HR data. So we get staffing data, which is turnover, vacancy, sickness. We get banking agency usage. We get mandatory training, including all the safeguardings, and we get appraisal rates. We do ask the trusts to fill in the serious incidents as well. So it is data that we can get nationally, but we do like to cross-reference the data that they have sent in to make sure that it does match with the national data that we'll get. And we also ask for complaints and compliments, and then we get certain areas of narrative, such on the innovations that the trust are taking out or key challenges that they're actually facing. The next slide shows an element of what's actually discussed in the RPM, which is coming from something which is called an intelligence summary report, or an ISR. And this is just high-level information about how we summarise whether we need to go in and inspect or not inspect. So the example that's given here is they're looking at the core service community adults, and then the intelligence recommendation is to not inspect. And we assume to not inspect based on them following indicators. If there was some indicators which were flagging, for example, vacancy rates might be at 40% throughout the year, sickness might be at 60%, that might be an indication that actually, are the staff correctly, and do we need to go and inspect that? As we move on, we do have a product called CQC Insight, which is available for acute community mental health and ambulance trusts. So Insight's a product which has a whole host of data points in, and we run this every month, and within CQC we have access to a dashboard which we can go on and have a look at the data that we hold about the trusts. The next few slides are examples of what CQC Insight looks like for community services. The caveat that I will put around this is there's not a lot of national data available for community services. I think Insight really works for acute. For community services, I don't really think that there's a lot of data in there which is usable for ourselves. The next point is about evidence appendices, which are the main repository of the data and facts used to underpin judgments of the main reports. So intelligence put in the basic facts. So you would have the mandatory training compliance rate is 60% for community adult core services. That is the basic fact. Then we would list the actual training courses. What the inspectors can then do is add a bit more narrative towards that when they go on site, and speak to the people on site. They might say, yeah, that course is 60%, but we've got a program in place to get that up to 95%, which would be the trust target within the next 2 months, and show evidence around that. Then the inspector could write something in the narrative about the actual data. What we put in there is just basically, I want to say, the cold hard facts. The next example is just actual table which will go in there and how we'll actually fill it in. The next slides are talking about how we actually monitor IH. And like I said previously, the main difference is that there's no RPMs for independent health services.
Sorry, Dean, can I just
sorry.
clarify? IH is independent health
Sorry.
for specialist advisors as opposed to NHS.
Yes, sorry about that. The main difference is there's no RPM for independent health services. We still send out provider information requests, there's still inspections, and there's still reporting. So due to the volume of independent health locations, we operate in intelligence a batch process for sending out the PIRs. So there's a set number of batches per year, and there's a 3-month window for an inspection to occur within. Again, the provider has 3 weeks to complete it. Then provider next will send a copy of the PIR to the inspection team 1 week prior to the inspection for all single specialities, including hospices. Other IH services, independent health acute hospitals, they receive a data pack instead of just the PIR. Data pack is some of the key elements from the PIR just put in a data pack so the inspectors can actually look at these. The next slide is an example of the batch process. You get the Signum deadline put in, then the PIR format, and we send all on the same day in week 1. The PIRs with the providers, and then they come back to us, and then we get time to build the data packs and send on to the inspectors, and then the inspection window is a 3-month period, and we'll do that on a rolling basis for independent health. CQC Insight has just been launched for independent health services, but there's no output yet because of the lack of sufficient quality and depth of the data within there. But obviously, if we do get more information in there, then we will publish that at a later date. Within NHS and independent health, we do have data development programs in place. So in CQC Insight, we are looking to add new data streams and developing new products. The PIRs, there's an annual update to build on lessons learned. So if providers do come back with questions about the PIRs, we will look to improve them. It's been an ongoing basis for the 6 or 7 years that I've worked in this area. The evidence appendices, we've got something called metric improvement, which is taking place. So instead of report on single data points in time, what we've looked to do is start to look at SPC charts to monitor risks and trends in the data. And again, we're liaising with stakeholders and other arms and bodies to access other data sources to try and reduce the RPIR and improve data quality where possible. That is a quick run through of intelligence. I take any questions if there is any. Or have I blew everyone's mind?
Well, you could say that.
Thank you very much, Dean. If there are any questions, that's for stepping in at the last minute and delivering it so competently. You definitely weren't winging it, were you? You know exactly what you're talking about. You just hadn't ever seen the slides until this morning.
Yeah.
Thank you very much,
Not a problem.
Dean. And
Thank
I think
you, Dean.
Thank
you.
Thanks, cheers. Bye.
I think it's over to me now, isn't it?
Yep.
So slide 47 for those of you on the call. My name is Helen Vine. I am the Sector Delivery and Oversight Manager for the Community Health Sector. And I'm going to talk to you about inspections and some of the practicalities and the pitfalls. And as previously stated, if anybody's got any questions, I'm happy to take them as I go along, and there will be an opportunity at the end of this session also for you to pose your questions. So slide 48, I'm going to talk a little bit about CQC principles and values, about what happens prior to the inspection, about your role during the inspection, and some of the characteristics of inspection activity which mean that it works really well and enables you to make an outstanding contribution. So first of all, slide 49, CQC's principles. I'm sure that you've looked at these slides probably ahead of the call, and I'm not going to read them out for you, but just basically to say that this is our starting point. So we are about people who use services. That is the keystone of the work that we do, and for many of you, for all of you, I imagine that is the case. We are all working in healthcare because we care about patients and the service users. We've just all got slightly different jobs to do in that system, haven't we? CQC as a regulator, though, has to be independent, rigorous, fair and consistent, and that's what we strive to do. I know we don't always get it right, but that is our aspiration. We have an open and accessible culture, and we're working in partnership and promoting equality, diversity and human rights. So those are the principles that you're all aspiring to and signing up to as a member of the CQC team. On slide 50, there's an outline of our values, and in the notes section, under each of our values, we have a list of statements which explains what we understand those values to mean. Again, I won't read them all out for you. I'll let you read those at your leisure, but the four main things are excellence, caring, integrity and teamwork. And obviously when delivering an inspection, teamwork is absolutely key, as is our integrity around being an independent, fair regulator, and excellence in searching out for the best evidence that we can find in order to give a robust judgment. So on to the detail. Slide 51, pre-inspection. So there's two, as you've probably picked up throughout the presentation, there are two types of inspection that we deliver, one in the NHS and the other in the independent health sector. And they have slightly different processes, both prior to inspection and during the inspection. So for the NHS, we have what's called a regulatory planning meeting, as has been described previously, and that is where the team delivering the inspection, along with our analyst colleagues, our intelligence colleagues, produce a plan for that inspection, which has to go to a meeting with sign-off by a Deputy Chief Inspector. So their proposal is challenged and considered, and it may be, we do have occasions frequently actually where the plan is changed based on those final conversations. But once that regulatory plan is agreed, that becomes the inspection plan for an NHS provider. For the independent health sector, we have an inspection planning template which the individual inspector produces, and in independent health we inspect everything that the provider delivers each time we cross their threshold, whereas in the NHS we select only those core services that we feel require an on-site inspection. So in independent health, the inspector will produce their plan, and then they have to have a meeting with their inspection manager to get that plan signed off. So once the plans are signed off, whether it be a regulatory plan or an inspection plan for the two different sectors, the inspector then, leading the inspection, is free to make the request to our flexible workforce office colleagues around what specialist advisors they need to support that inspection activity. And as Sue's explained, flexible workforce office essentially check any conflicts of interest, which is why it's really, really important that you maintain your data accurately on our Signum system. Otherwise, you could be notified of an inspection against which you have a conflict of interest, which would be extremely inappropriate. The request then goes out, and once a specialist advisor has been allocated to the inspection, the inspector is advised, and they will then make contact with the specialist advisor to share the relevant inspection plan or parts of the plan which are appropriate to the bit that you're going to be involved in. So slide 52. So once you've received contact from your inspector lead or inspection manager lead, these are the sort of things that we are asking you to do. So in terms of your role as a specialist advisor, you are there as a specialist in that particular service. Please remember that the inspector is the leader in this context, and it is really important that you follow their lead, that you follow their plan, and you do the work that they ask you to do, because they will have a detailed plan in which they will have allocated out different roles to different people, and if you decide to do something that's not on your work plan, you may be duplicating effort and then leaving a gap which needs to be picked up later. So please don't go off piste. If you feel that there's something that you've exposed that needs to be followed up, go back to the inspector and share that with them so that they can make a decision. We expect our specialist advisors to provide advice on service specifics. We are regulators. A lot of us have got, well, most of us have got healthcare backgrounds, but they may not necessarily be our specialist area that we're inspecting. What our specialism that we contribute is the regulatory aspect. You may be expected to support interviews with staff, and on occasions in community services, you actually may be asked to lead those interviews because of the geographical geography and the dispersed nature of services and how we have to divide the inspection teams up. We also ask that you observe care, that you review records, and that you follow patient pathways on some occasions. Some inspectors, not all of them, and again there are multiple reasons for that, but some may inspect you to review their draft report and provide comment on it, or they may send you certain sections of that report and ask you to make comment, particularly if there is something relevant to your specialism that they want to check the accuracy of. Occasionally we attend out of hours unannounced site visits, and we may require specialist advisors for those visits. And we also, of course, because we put patients and service users at the heart of everything we do, we really would like you to speak with patients and relatives to gather their views and their experiences. Slide 53. I'm now going to talk about evidence gathering. Before I move on to that, are there any questions at this point? I'll take silence as a no. So
Hi,
moving
can
on
you hear me?
Oh yes, hi. Go ahead.
Can I just ask a question? Now that we're being run by the mental health team, supporting the community inspections, they don't have a lot of 100% understanding of physical health and community adults, etc. It's new to them, certainly new to us working with them. We don't seem to have any corroboration anymore, and I just wondered what your thoughts about that were.
Okay, so thank you for that feedback, and I will pass that on. So for those of you on the call who are a little bit confused about that, we have recently reorganised within our internally in CQC. So we have acute teams and we have mental health teams within our hospitals directorate, and our mental health colleagues have now started to deliver community health inspections. They deliver community health inspections currently within their mental health specialism as well. So they are still regulatory experts, and the role of the specialist advisor is still to provide specialist advice around the particular service that we are inspecting. Internally, we've done some training. We have delivered, and we are continuing to deliver some training to upskill our mental health inspectors in their understanding of physical health, where there are gaps, which we have identified. So hopefully, and if any feedback from you as you are on inspections, where you yourself identify gaps in the knowledge or understanding of the inspection teams, would be greatly received by us. In terms of the corroboration, I'm sorry, I didn't get your name, the lady who spoke.
I'm Elizabeth Gradwell. I've done 2 mental health inspections now, and I've got another one next week. And as I say,
so community health inspections with our mental health inspector, specialist.
Physical health, community adult inspections and normal stuff, but led by mental health inspectors now.
Okay, and you said there was no corroboration.
No, I've had none both times.
Okay, I will feed that back, and maybe separately you could drop Flexible Workforce Office a message to let us know which inspections they were. Offline,
sure.
No, I don't. Yeah, thank you, and then I'll pick that
Yeah,
up.
if you can send that to me, just directly to me, that would be great. It's Sue here, Sue Hawkswell.
Okay, I'll do that. Yeah, thanks a lot.
Thank you, Elizabeth.
Helen,
Thank you.
can I just add something to that?
Mm.
So the methodology of what we're doing hasn't changed at all. All that's changed is the teams that are delivering those inspections. So as Helen said, if you go out and things are being done completely differently, or there's a bit of the process that you think isn't happening, we'd really like to hear about that.
Yes, thank you, Helen. Okay, so I'll move on to evidence. I've got a couple of slides on to talk about evidence. So there are several ways in which we gather evidence whilst on inspection. So we can run focus groups with either with staff or with patients or service users and their families, carers. We only use focus group methodology in the NHS usually. We also speak with staff, so not informal is probably not the right word, but during the delivery of their normal day-to-day activity, or in specially scheduled interviews for some key members of staff. And that can be out in the community or at service locations. Obviously, our conversations with people who are using services, also via observation, so watching what happens, or by tracking pathways for certain patients or conditions. We also look at patient records, and I'll come back to this a little bit later on. And we may look at, well, we do look at policies, guidance, and other documentary evidence. And in addition to that, we look at physical equipment, for instance, and the nature of premises in terms of their safety and effectiveness. And that's something, particularly if there's specialist equipment, that we might specifically ask you to support us with. When we're looking at that evidence, there are some key things that we need to consider. First of all, we would never make a judgment based on one piece of evidence alone. So I think it used to be called triangulation, and now we call it, as Elizabeth mentioned, corroboration. So we will always check the validity of one piece of evidence through the gathering of at least 1, 2, or even 3 more pieces of evidence about that same fact. We will need sufficient evidence to make a clear finding, so we would definitely not make a judgment on one piece of evidence alone. And as I said, in relation to patient records, please use the necessity test. So we need to consider whether it's absolutely necessary to review patient notes and records. CQC inspectors do have a warrant which permits them to look at that information, but we will only look at patient records if we need that that information and we can't find it elsewhere. So we obviously balance continually the person's privacy against the public interest served by gathering that piece of evidence.
Sorry, can I interject again? It's Elizabeth again. Sorry. Now that most of the patient records are electronic, there really is no need for this all this checking of records, because the system 1 and EMIS, for example, are so solid that, you know, to be checking for initials and things, dates, etc., is very old-fashioned. And I do think that should be in the system, that if we're checking electronic records, which we are, you know, do we really need to now? Also, sometimes computer access, they don't like us to be there checking on the computer. I know we can, but it's difficult, and you have to have a member of staff sitting next to you, which again takes up their time, which I'm not sure is really very helpful. So just another thought.
Yeah, yes, I think checking the records is quite important, because it's not necessarily those dates and things that we were checking before, but the quality of what's written can be quite variable. So it is trying to make.
It's not translated.
Sorry, thank you for your contributions. And I was going to say what the last person said. Actually, when I'm talking about looking at patient records, I'm talking about checking that risk assessments have been done, that conversations have been had around end of life, for instance, that the appropriate information is in the records. It's not just the sort of mechanical process of those records. It's about, you know, how that reflects the individual needs of the patient and how those needs are being met. I hope that sort of clarifies that. Okay, so moving on to slide 55. So when you're looking at evidence, the sort of questions we need to be asking is the evidence reliable? So is it hearsay, third-party evidence, or is it actual data that you know is accurate? Is it current? So as a general rule, the evidence that we gather will only be within the period post the last inspection of that service. So we won't be looking at things that are, if we inspected that service 2 years ago, we won't be looking at anything that predates that 2-year period. Can we use the evidence? So is there something to prevent us including it? And sometimes evidence of a very personal nature, which might identify an individual, has to be anonymised in some way. So those kind of questions we need to ask ourselves. When you gather a piece of evidence, does it say anything about the service's wider processes and governance, and does it need to feed into our assessment of the well-ledness of the organisation? Is there anything that we need specialist input in terms of analysing the evidence, and where does it fit in relation to the regulations, which are our legal remit for our inspection activity? Slide 56, some lessons learned for you, just some examples in terms of note taking. So when you gather your evidence, you record that evidence in a note taking template, which you then hand to the inspector at the end of the on-site inspection. So you do not take that information home and type it up for them. You have to give it to them before you leave site. So it's really important that you write legibly and that you organise your notes in such that the inspector will be able to use them afterwards. It's actually, I'll talk about this again in the next couple of slides, it's absolutely devastating for an inspector when you've gathered some really good evidence, but then the way that it has been recorded means that it's useless and they're unable to add it to the evidence in the inspection report. So some examples of good note taking, for instance, we see things like care plans didn't contain all the required information. What we need to know is what was missing, and sometimes it's helpful to draw on your notes, maybe a table, and list the items that you're looking at down one side, and then maybe a tick box for have they all got a risk assessment in for I don't know, pressure ulcers, for instance, and is there a DNA CPR, is it correctly completed, that kind of thing. So sometimes that just helps us if you present it in that format. Infection control was good. That's not evidence, that's a judgment. So why was it good? What was good? Did you observe good hand hygiene practice? Were staff using PPE? Was there use of isolation facilities where appropriate, etc. A comment, a handover was unstructured. In what way was it unstructured? What was it that was missing from there? Those sort of qualitative comments are really important. So staff said not enough doctors. That's a piece of evidence that is subject to an opinion by a staff member. So how do we corroborate that against the data? So what were the required staffing arrangements for doctors? Did we look at the rota to see whether that mirrored the requirements? And then how did they arrive at those numbers? And was that calculation done in a safe manner? Staff participate in national and clinical audits. Great. What audits do they participate in? And how did that inform improved practice? So hopefully you're getting the idea around the sort of evidence that we need to be able to use in our inspection reports. There's a photograph on slide 57 of an actual inspection note-taking template that was submitted by a specialist advisor. I'm not sure about you, but I find this very difficult to read, and it's really difficult to understand what that evidence would inform in terms of judgment. There are some abbreviations used in there which may not be common to everyone, so just an example. And that's really a shame, because that specialist advisor will have probably made a really good contribution on the inspection, but we're unable to use any of the evidence that they've gathered or provided to the inspector. On slide 58, I'm afraid there's a bit of a shadow on that, but this is the kind of evidence that's much more useful to us and formatted in a way that is easy to understand. So 5 personal files were reviewed in relation to, and that particular specialist advisor has listed each of the things that they looked at in those files and what they found in relation to that particular issue. So that's extremely useful. Any questions about evidence gathering before I move on to?
Yeah, it's Pauline here.
Hello, Pauline.
I wondered, hi. So one of the inspections that I went on, one of the inspection leads advised us to not leave any gaps. So if the sentence ended in the middle of the page, to draw a line down the end. I wasn't sure whether that was mandatory or it's just a particular inspector's kind of way they like to run it. But I mean, I could understand not leaving the gaps, because obviously assuring that there wasn't, nothing's been tampered with post writing it. But I just wanted to hear what you had to say about that.
Yeah, okay. I think the first thing I'll say is that we're all individuals, aren't we? And every inspector has, whilst working to the overall methodology, will have particular things that they like doing in certain ways, and that's okay, because we're individuals. In terms of contemporaneous note taking, that is actually the correct way to do it, and you are also supposed to sign at the bottom of every page and date it, etc., etc., to avoid anybody tampering with the evidence. I think that from a pragmatic perspective, and if that inspector wants it delivered that way, then that is the way that I would expect you to record your notes. However, given that you're handing them over at the end of the day and you're keeping them with you all the time on inspection, you're not putting them down for a staff member to pick up and see or anything like that, the likelihood of them being tampered with is probably relatively low. Does that help?
Yeah, no, that's very helpful. I mean, yes, he advised to sign each page, and I've kind of been doing that ever since, really, just because I thought it was good practice. But yeah, I just wanted, and I understand the sort of differences in just people's own unique way of running things. I just wanted that clarification, whether it was kind of, it was mandatory but I think that what you're saying is very helpful.
Okay. I think the other thing I'd say about note taking, and you prompted me, so thank you for the question, is it's really helpful to include timings on your notes. So if you are interviewing somebody, If you put the start time of the interview and the finish time of the interview, that's also really helpful for us in terms of evidence. And if you move from one location to another, if you can put the time that you left, that particularly if in the community, if you're moving around different clinics, for instance, if you put the time that you leave the clinic and the time that you arrive at the next clinic, that sort of helps the inspector sometimes around the evidence. Occasionally we're challenged about taking staff away from patient activity, that kind of thing, and it can be really helpful to be really precise about how long we were with that person. So timings, if you can remember to add those things. It's a bit like learning to drive, I think, on your first few inspections. There's a lot to think about, but you soon get into the flow of it. Okay, so I'll move on to slide 59, briefing and corroboration. So corroboration is where everybody brings together the evidence that they've found, and the inspector will lead the session to try to pull together a picture under each of the key questions of the evidence that we're gathering and the emerging findings. So usually we would expect on NHS inspections corroboration sessions to be held at least once a day. When you're doing an independent health inspection, those sessions may be less formal and more informal during periods, so possibly when you have a tea break or lunchtime, or through conversations with the inspector during the course of the day. They may actually do that on a one-to-one basis with different inspectors. But the purpose of corroborating is to review emerging findings and then to understand if there is a further line of inquiry that needs to be followed up and where to target the gathering of evidence where there is. For
Hello?
Helen, I think we've lost you there.
Yes.
Oh, sorry. Hi, can you hear me?
You now, yeah.
Hi,
Yep.
sorry.
No
What
problem.
what was I saying when you lost me?
So you were up to, I can't remember exactly what you just said. We literally lost about 20 seconds.
Okay.
Don't worry,
So,
you hadn't
Just
been
about
talking to yourself for
meetings, I
ages.
think.
Yeah.
Corroboration and meetings.
Corroboration.
Okay. So did you get the bit where I said sometimes the corroboration might be sort of informal and the inspector might go around individuals if it's a smaller service rather than having a meeting? Okay. Yeah. And then they may decide that they need further evidence about under one key question. So if there's something about the service that's good and they believe that they might be able to tip it into an outstanding rating, they might ask you to go and gather further evidence to support that that rating in that particular proposed rating in the report. And sometimes what happens, this happens a lot, and different members of the team go out and they might find a concern or something that's notable about people's practice, and they'll come back and say, do you know what, they're really good at, I've not seen it done that way before and I'm really impressed. And somebody else will say, I saw that as well in so-and-so. And so it's the way that we pull together all that evidence through the corroboration. Slide 60. So we are starting to summarise now. So how to be outstanding as an inspection team member. And please just remind you about confidentiality in public spaces, actually when you're in the trust or the provider and outside of that. So in terms of social media, just be mindful of what comments you're making, maybe not posting where you're travelling to and that kind of thing. Please don't promise to personally resolve any issues for patients or other individuals. It's very difficult. We all care passionately about patients and their experience. However, it is the responsibility of the individual service to do those things, and you are not in a position to make any promises on their behalf. If an individual makes a complaint to you, please refer them to the individual provider's complaint procedure. So that gives that provider the opportunity to address that complaint. Please remember that you're representing CQC during the inspection, and I think it was Ian mentioned this, right at the top of the call about giving advice. Please do not make recommendations or give advice. And the reason for that is that you are there to carry out an independent assessment of the service that's being delivered under those key questions. If you make recommendations or give advice, you compromise the integrity of that inspection. And it is not our role to tell providers how to do something, because then when we assess them against that, effectively we're marking our own homework, and that is not our role. We are there to support services to improve, and we do that by identifying where they fall short of the regulations. So please dress appropriately also, no branding, and obviously in clinical areas follow the appropriate policies and procedures. Moving on to slide 61. So just to recap, I've mentioned these things before, but these are the characteristics of an outstanding specialist advisor: someone who reads the material that the inspector sends in advance of the inspection, so they're prepared. Attends a briefing call if the inspector has one, so sometimes they'll set up one for all of the services, and sometimes they'll have a one-to-one call. And sometimes there won't be a call in advance if it's a short notice unannounced inspection. It'll be a meeting and a briefing actually on site at the time of the inspection. Please follow the instructions. As I said before, remember, don't go off piece. Do the bits of work that are allocated to you, and then go back to the inspector once you've done that and ask what else they'd like you to do. Be mindful of the quality of your notes and try and follow the principles that we've outlined. Keep to time. Inspections are a bit dynamic and fluid, and the plan can be turned on its head within the first half an hour if there is a very serious concern that's identified. So a bit of flexibility on your part is always welcome, and being willing to adjust to new timeframes. Keep an open mind. Bring all of your experience and expertise with you. We really welcome it, and we hope that you find it an enjoyable and rewarding process. Moving on to the next slide, we are trusting you to uphold the values and principles of our organisation and regulation, to show empathy and respect for patients and also for staff, and I'm sure you will do that because we've all been on the other side of this process at some point, and we know how scary and challenging it can be at times. Give your full commitment and attention to the process. If there's something going on in your day job which means that you need to be on call, or you may have to take phone calls during the inspection, please can you consider whether it's appropriate that you're there, because it really does require your full attention. The next one is constantly a challenge, I think, for all of us, having the courage to call it out in the face of good people doing their best. Generally in services where things wrong or are not working in the way that they should be, and patients are not getting the quality of service that they should expect, it's often not about individuals, it's about systems and processes. And it's really difficult to say to good people who are doing their very best, this service is providing a suboptimal standard of care. But that's what we need to do to support those good people to get changes in the systems and processes. And also to be kind and courteous. It's really scary for people who are undergoing inspections sometime, and we find that getting the best evidence from people relies on us being as kind as we possibly can and courteous, and maintaining those professional boundaries around not giving advice, not making promises to patients that we are not in a position to deliver on, and so on. I put a note in there to sort of give you an example around the advice thing. So you should never say, in my service we, or this is what we do, or this is what you should be doing. It might be more appropriate if you need to pass a comment but I try and avoid doing so if you can. But if you do need to, the sort of things we would say is providers who are rated good, you do it this way, or that's the kind of the way that we would frame it. But avoid giving advice in most circumstances. So just to summarise, when it works well, we actually end up with sufficient evidence to conduct a thorough and fair inspection. The evidence covers all of our key questions and all of the key lines of inquiry. We have linked that evidence to the regulation, so we're very clear if any breaches have taken place, and all of the above allows us to make judgments that are a fair reflection of the service. What we want the service to see is that we've held a mirror to them, and what they see in that mirror is what they understand they are providing. So ideally, there's a shared view of quality. We've identified where there's innovative and outstanding practice, and we've gone back and gathered enough evidence to be able to include that in the report, to be fair to that service and to the staff working in it, and to those patients who use it. Where it's an NHS inspection, we've identified any areas around leadership, governance, risk management, etc., which can feed into the well-led review, which will happen at a later date usually. And we've all contributed to a report that will help the service drive improvement. And that's the end of my section. Just moving on to slide 64. I'm happy to take any questions at this point, either for me or for previous presenters.
Hello, it's Gail here. I've just done a recent inspection and I've thoroughly enjoyed it. It was a fantastic experience, I must say. But we had a mismatch of documentation. So do you have a repository where I could go as a SpA and say, right, this is what I need for this interview, or this is what I need for that interview, or do you have anything like that?
So was it an NHS or an independent inspection?
It was an NHS, but we had different sort of templates. You know, there was a mixture of things.
So the materials. Sorry, but those.
No, I'm just saying. Couple of the inspectors just sort of said that they tend to collect their own bits and bobs and give those out. So I didn't know whether there was sort of like a national, like a standard repository for all the documentation.
Yeah. So Sue, specialist advisors have access to the intranet, don't they? CQC.
They don't. No, not
they don't.
There's an internet page that they have access to. But we don't have inspection templates on there because obviously they change quite regularly, and with covering 3 directorates, we're not, to keep that up to date.
Yeah. Okay.
It's
no,
very
that's
difficult.
Fine.
Obviously the intranet's updated, and the expectation is that inspectors will take the paperwork for the SpAs. Yeah.
So they're inspectors, we do have on our intranet a repository of all those documents. So all of the templates for all of the inspections, both independent health and NHS. That said, there are occasions where inspectors adapt those templates. I'll give you for instance, and I don't know if this is what happened in your case, but if there is a specific risk or a specific issue that needs to be unpicked. So for instance, if we've got a concern about equality and diversity or safeguarding, for instance, then the template relating to an interview with a safeguarding lead may well be adapted by the inspector to target the specific questions that they need to ask to get the evidence relating to the concern. Does that make sense?
Oh, well, that's helpful. Yeah, no, that's helpful. Thank you.
So as with everything, templates are there, but we will adapt them if it serves the purpose of the individual inspection. But there should be standard templates for everything.
Okay, thank you.
You're welcome. Are there any more questions about the operational aspect of inspections?
I can just say, if I can comment, I think it'd be useful to have this sort of training done on a regular basis for new SpAs, because and it seems to be very ad hoc in the past, because this is the first sort of induction training I've received, and I think I can see it could be very useful for a new SpA. But I have been with other SpAs who have had some other sorts of induction, but I say this is the first sort of induction I've received or been invited to. But it's a long way down the line, because I must have been doing inspections for about 4 years. But I just say I think it's good to see that you've developed this.
Good, thank you for that feedback. You were probably one of Mike's original army, weren't you?
Probably. Yeah.
Yes, we are. We have developed induction packages for all of the sectors, and we're working through them. So that is good to get some positive feedback around that. And I think any suggestions that anybody's got for ongoing training, education, or engagement would be really welcome. We're looking at developing our engagement plan with our specialist advisor workforce, and any suggestions we'd be really grateful to receive.
Okay, if I can just say, I did attend a meeting of specialist advisors at the Leeds office. It was about 2.5 years ago, but it was very poorly attended because, to be fair, nobody was paid for going, and I only went because I happened to be in Leeds at the time. But it was a whole afternoon, and if you took into account travel and everything, it did involve probably a full day for some people. But I say that I understood that the turnout was very poor because nobody was actually been receiving any remuneration to attend, which was sad, really. And I do think it is a bit of an issue at times for specialist advisors in terms of the fees that they are paid.
Okay, thank you for that feedback. We'll consider that in terms of our engagement and training going forward.
Mm-hmm.
I think that's it. It's just so sorry to butt in there, Helen. I think
go ahead.
It's about striking a balance between the sort of costs and the logistics of it all, the availability of professionals. We're very aware that people do have day jobs that they need to prioritise over their SpA work, and it is very difficult for us to kind of pull face-to-face events together, but we would appreciate feedback around ideas that you have as to how we can engage better with our flexible workforce.
Pauline here. I think actually this sort of engagement and training is probably a good balance, because like previous person said, people are obviously dotted around the country in various different places. Yeah. So this is ideal, really, I think, and it's been really useful.
Oh, good. Thank you. Well, I think if anybody does have any feedback, please feel free to email me with it. It's sue.hawkswell@cqc.org.uk, and I'll obviously share that with Helen to move forward with any further engagement activities. Is there any other questions?
Give it some thought.
Yeah. I mean, 2 heads are better than 1, so we've got 13 on the call today, so 13 is definitely better than my 1. It's got to be something that we can all sort of buy into and can all engage with. And I know that we did have quite a good response rate today, but if just to put it into context, the invite was sent to 91 people, and we've got, I think, 11 specialist advisors on the call, I think. So it is quite difficult to organise these things.
I was just going to say, just a point, but I didn't notice anything on the email to accept the invitation for today. I mean, I just saw the dial-in details and obviously put it in my calendar. But there wasn't anything to accept, was there? To give you an indication of how many would attend?
There was quite a few people emailed me directly as well,
Right.
and sort of said, "Oh, I will be, I won't be." So yeah, there was. I did, got quite a good response rate, which in itself is a positive, because it means that people are speaking to us. It's just disappointing if people can't always make it. So, but we'll be sharing the recording of the call anyway with everyone who couldn't make it and with yourselves, just so that you've got it there as a reference point. Is there any other questions?
No, that's fine.
No.
That was very
not from me.
informative. Yeah.
Fantastic. Helen, do you have anything else to add?
Not from me. I don't know. Helen, Peyton, do you have anything to add?
I don't think I do. Thank you.
Okay.
Just to say thank you to everyone for giving up your time to dial in and for your feedback, and we look forward to you supporting us with inspections, and I hope you enjoy the role and the process.
Okay. Thank you very much, everybody.
Thank you.
Thank
Thank
you.
you.
Thank you.
All right.
Thank you.
Thank
Bye.
you.
Bye.
Bye-bye.
Bye.